Hi, everybody. Welcome. We're going to let folks come in. Just give us a second while folks are able to enter the webinar. We're really glad to have you here. Welcome. All right, why don't we get started? My name is Sam Brooks. I'm the Director of Public Policy here at the National Consumer Voice for Quality Long-Term Care. We're really glad to have you today for our webinar, No Excuses, No Delays, Strong Nursing Home Staffing Standards Now. We're conducting this webinar today in conjunction with SEIU, a wonderful labor organization that represents thousands of CNAs across the country and in nursing homes and home health workers. So we're really grateful for their participation, and we're really grateful to have all of you here. Next slide, please, Libby. To tell you a little bit about the Consumer Voice, hopefully you know us, but just in case, we are the leading national voice representing consumers and issues related to long-term care. We advocate for public policies that support quality of care and quality of life, responsive to consumers' needs in all long-term care settings. Our goal is to empower and educate consumers and families with the knowledge and tools that they need to advocate for themselves. We train and support individuals and groups that empower and advocate for consumers of long-term care, and we promote the critical role of direct care workers and best practices in quality care delivery. Next slide, please. SEIU, as I mentioned before, represents 2 million workers in the United States, Canada, and Puerto Rico, and that includes 180,000 nursing home workers in 25 states in Canada. And again, we're really grateful to have SEIU participating today. It's been documented that organized homes provide better care. Next slide. So just a couple just brief housekeeping issues. This program is being recorded. If you have questions, and we hope you do, please use the Q&A feature at the bottom of your Zoom box there. You please feel free to chat and talk amongst yourselves. I already see folks talking, and we're really glad for that. And please complete the evaluation questionnaire when the webinar is over. All of the slides in this recording will be posted in the chat box and we'll be posted in the chat box and will be posted into the Consumer Voice website. Again, let's get started. So we're here to talk about staffing. And as many of you know, in March 2022, President Biden announced some of the most ambitious nursing home reforms in decades. Central to those reforms was the implementation of a minimum staffing standard in nursing homes. For the first time in history, there would be a federal requirement that each nursing home resident is entitled to at least a minimum amount of direct nursing care each day. The announcement for residents, workers, families, and advocates was a realization of years, decades of tireless work. As we all know, or you should know, that staffing is the key to better outcomes in nursing homes. It is absolutely irrefutable that residents who reside in nursing homes with sufficient staff experience better care and health outcomes. Additionally, a requirement that nursing homes spend the tens of billions of dollars, taxpayer dollars, they receive each year on staff would create better jobs and reduce turnover in nursing homes, staff turnover. Most importantly, better jobs would mean better lives for the hundreds of thousands of nursing home workers across the country, workers who labor tirelessly but are often paid near poverty level wages. Since the announcement, all of us, residents, workers, families, and advocates have worked hard to ensure that the resulting staffing standard would be strong. Centers for Medicare and Medicaid Services, CMS, the agency charged with implementing the standard, has worked quickly to implement the proposed standard. CMS issued a request for information, inviting comments on what a staffing standard should look like. Additionally, they conducted a staffing study that helped inform the proposed standard, and they issued the proposed standard in September of 2023, and to which they received over 40,000 comments. And now we're all waiting to hear what that final standard may be. However, from the outset, the nursing home industry pulled out all the stops, investing millions of dollars in TV ads, lobbying, and other efforts to derail and stop a minimum staffing standard. As is routine, when the nursing home industry faces new regulation, the industry inundated CMS and Congress with tales of how a staffing standard would result in nursing homes closing. These constant refrains, included claims that there are not enough workers or that rural facilities would close. These claims were made absent any evidence that rural nursing homes face any more hiring challenge than non-rural homes. Yet these arguments have convinced some that requiring nursing homes to provide a minimum amount of care is not good. Lastly, the industry claims that a minimum standard is an unfunded mandate and that there just isn't enough money to pay workers living wages. However, throughout all of this, frequently what was lost in the discussion have been the voices of residents and workers. Consumer Voice, SEIU, and others have held numerous rallies and webinars to elevate the voice of residents who suffer and die from inadequate staffing, and workers who, charged with caring with our most vulnerable citizens, are often paid so poorly that many of them qualify for public benefits. But today, that being said, we are here again to raise up the voice of workers and residents. We are grateful to have with us today Sarah Cubba, Donna Wilkes, a nursing home resident from Washington, D.C., and Sarah Cubba, a medtech CNA and a member of SEIU from Oregon. And I said Oregon right, I think.
Yes, you did.
Forgive me if I didn't.
Okay.
And they will share their experiences of working and living in nursing homes with poor staffing. And last but not least, we have Ernest Tosh. Ernest Tosh is an attorney licensed in Texas and several other states. He's a former criminal prosecutor, but currently sues nursing homes for abuse and neglect. He's a nationally recognized expert on nursing home business structure, finances, and staffing. He has testified before the House Ways and Committees on the effect of private equity ownership on nursing home care, and he has traveled from coast to coast advocating for financial and ownership transparency in the nursing home industry. So enough out of me. I want to turn it over to Sarah, and she can share her story about working in a nursing home. Thanks, Sarah.
Thank you for having me today. Hello, everyone. My name is Sarah Cubba. I work in Oregon as a certified nursing assistant and a medication aide. It's important for me to be here today and to speak out for all of my fellow coworkers in Oregon who are just really, they're exhausted and they're sick and tired of the lack of oversight and accountability in our nursing homes. I'm actually very new to the industry in long-term care facilities. I've only been working in healthcare for 4 years. Before that, I was actually a restaurant manager for 14. I also recently just became a steward at the location that I work at. So right when COVID was happening, they were shutting down all the restaurants, and I was trying to figure out what I was going to do, what my next step was. So I got into healthcare. They were losing a lot of nurses, nursing assistants, med techs, all that, because people didn't want to work with COVID. And somebody had to step in and advocate for all the residents who didn't have anyone there to help them and take care of them. So with that said, I went back to school and got my CNA first, did that for a couple of years, and then I got my med tech, and then I've been doing that for about 2. I love working with people. I was raised by my grandparents, so I'm very close with senior citizens. And it's very important to me to get back to that community. I love getting close to my residents, and oftentimes their family members as well. It's really important to me to help in the fullest. There's a lot of physical and psychological factors that take in doing this job. It is very demanding, but I think I speak for all of my coworkers and myself. We absolutely love doing what we do. We are very short staffed as it is, although Oregon does have very good ratios comparison to other states. That ratio still, I don't think, fits the needs as far as, what they need on a daily basis to help take care of these individuals. So for what I do right now is I do pass meds, and a lot of the times with the short staffing, for me, what I have to do is I have to step away from my med carts. And whether there's call lights on or there's somebody yelling down the hall for help, I have to step away from what I'm doing to go help the CNAs, which happens a lot. But myself and other med techs and nurses that work there were more than willing to do that, of course. But the one thing that we are taught in med tech school is our job is very time sensitive. We have to get medications passed at a certain time. And a lot of times with the short staffing, that interferes with our work. So that puts that in jeopardy for people receiving their medications. So that's something that we are really worried about, being short-staffed. Across the country, nursing home owners are saying that they don't have the resources or ability to hire more staff or pay us more or put more resources into quality of life of our residents. And that's really frustrating, because that's something that we need as far as to have the tools to go to work every day to help these individuals live long quality lives. A lot of the times I see these bigger corporations are pocketing money and expenses of nursing home workers and residents, and they're not giving back into the facilities that need more than just the bare minimum. There was a point in time where the facility that I work at didn't have hot water in half of the building. And this went on for 6 months. And this is dangerous because people need hot water, and also it's infection control as well. And that's not okay. That's astronomically that just blows my mind. At one point in our dining area, we had asbestos falling from the ceiling that none of us were aware of. So our residents were being exposed to this. And, you know, it's just little things like, you know, even when it comes to not having milk in the facility, that's ridiculous. That shouldn't be happening. I know each facility is different, and they have different, what's the word I'm looking for, policies and procedures. As far as the ratio goes, I do think that they need to up and have more CNAs hired in these facilities, and then they need to get paid more as well. So I think that's one of the issues why we can't seem to be keeping home staff. We have a lot of different companies that run in Oregon that are agency, and they get paid a lot more. So it would be wonderful to see if these bigger companies could start putting more money into that as well, so that we could keep consistent staff in the building. But a national staffing standard, I think, would be great. I know that in other states, you know, like I said earlier, we're lucky in Oregon to have the ratio that we do, but I know in other states, they don't have that luck. Their ratios are way different. I mean, there's 15 residents to one person. That's not realistic in any, you know, what should be a standard. That's a little high. And I know that these bigger corporations, they have, you know, bad actors, and they say that they understand, or they say that they know what's going on. But I think that in a lot of different situations, like what I just described, it really kind of just shows and shines like, you know, they're just not putting in enough effort into these facilities and protecting the residents. I know that everyone that I personally work with, we all love our jobs, and we go to work every day. We put the time and the effort into it, you know, and we make the best of it. But I think that what really matters the most is that our residents are feeling safe, and they have that connection with the people that come in and work with them. And the one thing that I see the most that makes me personally sad is that when we're short-staffed, we don't have that time to really sit down and, you know, be there for the residents that we want to be, because we don't have the time. And if we have that staffing ratio in place, I think that it would be much more productive for us being able to actually sit and visit with people and put that more time into them, not just coming in and having time to do the bare minimum. But we work with what we have, unfortunately, for now. So it would be great for me personally and all my my coworkers and people that I work with and the residents if we have that ratio in place.
Great. Are you finished, Sarah?
I am. Thank you. Sorry.
Oh, great. Thank you. I didn't want to cut you off. Thank you. That was very informative. Obviously, thank you for all the work you do. I'm always amazed when I hear from workers and what they have to deal with: asbestos, no hot water. And I think one of the things that is so important to note is that we consider this a turnover crisis, a retention crisis, not a hiring crisis. CMS estimates that the average turnover in a nursing home for direct care staff is 52% each year. So you have to replace every other worker. And I'm sure you see tons of people come and go, paid low wages, put in impossible situations. So we're really eager to have a staffing standard that would require facilities to invest in workers, reduce turnover, and increase retention. So thank you, Sarah. You could tell from the chat that everyone was really inspired. So next, we're going to talk with Donna Wilkes. Donna is a nursing home resident in our capital, Washington, D.C. We're honored and excited to have you here today, Donna. And I'll turn it over to you to talk about what it's like to live in a nursing home.
Thank you. Thank you, Sam. My name is Donna Wilkes, and I live in a skilled nursing facility in Washington, D.C. Please excuse the fact that I'm speaking to you from my bed. Unfortunately, today is not one of my scheduled days to get out of bed. Actually, this is my second nursing facility. I first entered a nursing home at the age of 39 in 1992. These early years, though, were the best as far as staffing levels. In my first facility, there were 36 residents on my unit. We had one CNA for every 6 residents on morning shift. We had enough staff to be cared for as we needed. We got to activities on time. We got our meals on time. It was the best of times. From the late 1990s and into the 21st century till 2016, I'm still in the first facility, the ratio of CNAs to residents started to change. By this time, there was one CNA for every 7 residents, and most of the time our needs were still met in a timely manner. Overall, we generally had very good staffing levels at my first nursing home. However, this facility closed in late 2016. And in late 2016, I transferred to my current nursing home. But it's not a typical nursing home. Our facility specializes in caring for people with serious illnesses, especially those with severe respiratory problems. On one unit, every resident uses a ventilator and has a tracheostomy. Overall, residents here require a lot more care and a lot more staff than those who lived in my first facility. We have 39 residents on our unit. From 2016 to 2019, we had one CNA for every 7 to 8 residents. I began noticing changes in how long we waited for help before someone came. However, it was to become much worse after the pandemic started and after my facility pushed to go to 12-hour shifts. As we are aware, the pandemic did create many shortages in the healthcare industry. However, our staffing shortage was exacerbated by the facility twice attempting to implement 12-hour shifts. Most of the CNAs were opposed to the shift change and many quit. Eventually, in its third attempt, in February 2023, our skilled nursing facility changed to 12-hour shifts. We lost many more CNA employees, and now virtually all the nursing staff comes from agencies. Our ratio of residents to staff has also significantly changed over the past year. We average one CNA for every 13 to 20 residents versus 1 to 6 in the 1990s. And now there's been a significant change in the care we receive. I wait much longer to get changed now, and so I suffer from more frequent skin irritation. Almost every meal now arrives with the hot food cool to cold and hot water lukewarm. Okay? There's seldom enough staff to distribute the food trays in a timely manner. And we've had some other complicating incidents. For instance, our building is very old. It's over 100 years old, and it was never renovated before the facility took the lease for it as a skilled nursing facility. So as a result, the elevators, especially since Christmas Day, 2022, all our elevators, the service, the visitors, and the general elevators broke down at once. The staff had to bring our breakfast and lunch Christmas Day up. It must have been 20 flights of steps with about 10 steps between each, actually 20 steps between each flight. It's a very tall building, okay? And I remember Sarah mentioning that they went 6 months with no hot water. Well, because nothing had been changed, we still have the same old pipes and electrical wires. We have gone ever since 2016 without everyone having hot water. We have hot water here and there, and sometimes if you run the water like a half hour, it might get warm in some rooms, and in some rooms it doesn't get hot at all. So that's a little segue, because I thought about what Sarah said. This is a real problem with many old buildings because no one's interested in rehabilitating older buildings for nursing facilities. But go back to my notes, thank you. Before 2020, I was scheduled here at this facility to get up 6 days a week, every day except my shower day. I do stay in bed after I get my shower. Since 2021, I've been assigned scheduled 4 days per week where I'm able to get out of bed. Even so, there have been days when our staffing was so inadequate that I couldn't get out of bed or get a shower on the days that I'm scheduled to do so. It's often difficult for me to get back in bed before pain and fatigue set in for various reasons, including lack of staff. Even when the nurses outnumber CNAs, rarely do the nurses help because, as they say, they don't use Hoyer lifts enough to feel confident helping another nurse get me back to bed. So generally, alongside added pain and fatigue, and pain is by far the biggest issue I face, one of the most difficult problems with understaffing is my inability to plan for anything. Even when I've notified the facility managers in advance to say, for instance, I'd like to go out to church, I, along with the family member or friend who's arranged to go with me, have to wait until that morning to know whether or not we have enough staff, not only for me to go out, but even to get out of bed that day. I really hope this issue of inadequate staffing can be resolved so that our living experience as residents in nursing facilities can be of better quality. And I know better staffing is possible because I lived it. Thank you for listening.
Wow, Donna, thank you very much for that moving and also very concerning description of how you're living. I hope both you and Sarah will look in the chat and see all the support that you're getting from the attendees here, and also the shock and the outrage. And for folks attending, a nursing home resident, and all of you know this probably, should be able to get out of bed any day they want, and get dressed anytime they want, and go to church when they want. These types of perverse facts are just unacceptable. And this is why we need the face of residents like Donna and workers like Sarah to really bring home for people what really is going on in nursing homes. So thank you. I thank you very much. You know, so we wanted to talk about this webinar is a large part about staffing is possible. Safe staffing is possible. As Donna said, it's out there. And it occurs. There's thousands of homes right now providing more than adequate enough staff. Nonprofit homes provide staff at a rate almost 25% higher than for-profit homes. So once you pull back the layers of this discourse that there aren't enough workers and we can't pay them enough, you start to see that those arguments are just not true. And one of the biggest ones here is the money. We don't have enough money. This is one that folks have struggled with for decades, to show it's become just accepted, I think, by people on the Hill and CMS that, oh, you just don't get paid enough. Medicare pays a lot, but Medicaid doesn't. There's no way we can provide safe staffing. And fortunately, we have at Consumer Voice, we ran into Ernest Tosh, who is going to speak next. And Ernie is a guru when it comes to finances. And he's empowered us and many other people across the country to start to look at the actual finances of nursing homes and show how through financial hijinks, or shenanigans, as I like to say, nursing homes are very profitable, but they're hidden. Those profits are hidden. A paper just 2 weeks ago by two professors one from UCLA and one from Pennsylvania, they issued a paper that estimated that nursing homes hide 62% of their profits in related party companies. And Ernie will explain what that is. So the curtain is being pulled back, and no longer is reflexively are people saying, oh, there isn't enough money, we can't provide care. So we're really honored to have Ernie with us today. Ernie can talk to you about nursing home finances in a way that you can understand. And we're really glad to have you here, Ernie, and I'm going to turn it over to you and I'll shut up. Thank you.
Thanks, Sam. It's great to be here, everyone. I've got a short PowerPoint presentation to help explain how nursing homes hide their profits so that they can effectively stand in front of the legislator and say, oh, we need more Medicare money, we need more Medicaid money, when in fact, it is highly likely that they are already very profitable. It's just that they are manipulating the income statements that they file with CMS and which are seen publicly. And so for the last 12 or 13 years, I have been delving into this area, and my law firm sues nursing homes all over the country for abuse and neglect. And so we got into this deeper and deeper and deeper. I've now become an advocate. I travel the country discussing this, working with Consumer Voice on an effort to get states to pass legislation for financial and ownership transparency. And as I saw in the chat earlier, and somebody mentioned, you know, these facilities don't have money for staffing, but they can spend millions of dollars on lobbyists to keep us from looking at their finances. So that should be a wake-up call and a red flag. These facilities have a lot more money than they're willing to show. So I'm going to go through this presentation fairly quickly just to let you know. I've done this presentation and taken 3 hours to do it. So to do it in 15 or 20 minutes is, but we'll see. Next slide, please. So the common argument that we're hearing is, you know, how could the facility have staffed more? We have no money. We hear this in all our lawsuits. We hear this, you know, every time the industry comes out and says something publicly. They have a very unified message that all of them put forward, which is we need more money. We don't have the money for more staffing. Now, next slide. There have been 3 reports or articles that have come out in the last year that are very, very good on this point. The first one there came out last week. It's the one, and that one is a very approachable article. It's written by journalist Sean Campbell and a professor, Charlene Harrington. It's a very good article on the subject we're talking about today. The next one is the one that Sam was talking about that's done by the 2 professors. That is a very academic article. It is excellent. And then the last one down there is a report that was put out by Consumer Voice. Sam and I worked on that. It relates with or deals with related party transactions. And there's also some embedded videos there that we did to kind of help explain different parts of this process. So what we're going to talk about now is discussed in that article, and there are some videos in there that kind of explain some of the background that might make it more easily understood if you're interested in more information. Next slide, please. So the big thing that these facilities want to do is they want to manipulate their income statement. Okay, income statement, the very bottom of it, you know, it's what we all call the bottom line, is how much did they make or how much did they lose this year? Next slide. So if you've got, oh, I'm sorry, that last box should have had white lettering in it, so it's easier to read, but you've got an income statement. This is a very simplified one, but they have $16 million in billing. They have $1.75 million that they're unable to collect, which means that they had $14.25 million that actually hit the bank account. Then they had operating expenses of $13 million. So their net income is $1.25 million, so $1.25 million. And so that is where they're sitting. And if they show that number to the public, how are they going to claim they can't hire more staff? Next slide. So what they have to do is they have to manipulate it. They have to manipulate this specific document, the income statement. They can't manipulate the revenue. The revenue is what it is. You can't manipulate that. So you have to manipulate your operating expenses. Next slide. So the way you do that is you create a structure that looks like this, where you have a parent company. Today, we're going to call it Tosh Senior Care. And that parent company owns multiple nursing homes at the very bottom level. And then it has a real estate holding company. Recently, we've seen that they're actually creating a holding company for each facility. In the past, they had one real estate holding company. They'll have management companies, therapy companies, a pharmacy, a dietary, company. All these companies then do business with the nursing home, but all the money that flows from the nursing homes to these related businesses then flows up to Tosh Senior Care. So next slide. So this is what an actual nursing home looks like. The slide I used before is just easier to understand, but this is actually a very small nursing home company. We've been in litigation with one in California that has over 300 individual companies that come under the banner of the parent company. Just an unbelievable number of companies that do business with each other. And it makes for just an absolute, spider's web of financial transactions. Next slide, please. So the question is, how does the use of related parties impact staffing? Okay, so first, related parties are companies that are owned by the same parent company as the nursing home, or the parent company controls that other business, either owns it or controls it. So classic example of this is a real estate holding company. The real estate is held in the holding company and it's leased to the nursing home, okay? Both of those companies are owned by the same parent company. So those are related companies. It's like they're siblings, they're brother and sister corporations, and they do business with each other. Next slide. So what you have to do if you're this facility that just made $1.25 million is you have to get rid of the profit. You can't show that much profit, or you can't claim that you're bankrupt and need more money. And you can't claim that you have no money, so why sue me when I kill my residents? You have too much money, you can't say we couldn't hire more staff. So you have to manipulate the income statement. Next slide, please. So we take our original income statement that we had, and next slide. What we do is we go in, and this is what our real estate looks like, in day one. The real estate is owned by the nursing home, and there's a mortgage payment that has to be made. There's taxes that have to be paid. And so that nursing home is paying about $600,000 a year to have its building available as a nursing home. Next slide. So what they do is they move the land and building ownership from the nursing home to a related company, a real estate holding company, and then they lease it back to the nursing home for $2 million. So, next slide. When you do that, the difference between those two numbers is $1.4 million. And that's a siphon. A siphon is where you're taking more money from the nursing home than it costs the related party to provide that good or service to the nursing home. So in this case, it's a $1.4 million siphon. Next page. So what we've got here is our original income statement where we had $13 million in operating expenses, and part of that operating expenses, $600,000 of it, was the mortgage and taxes that this building was paying so it could operate. Next slide. So what we do is we increase our operating expense by $1.4 million. The cost of our building went from $600,000 to $2 million. So our expenses went from $13 million to $14.4 million. So now our nursing home shows a $150,000 loss, not a $1.25 million profit. Now, the owners of this facility can run over to their local legislators and say, look, we're almost bankrupt. You're going to require us to have staffing at a certain minimum level, and we don't have the money for it. I don't know how you expect us to pay for it. You're going to have to pay us more money, or we're all going to go bankrupt. Okay, does that sound familiar? I mean, ever since CMS started talking about a minimum staffing level, that's what the industry's been crying. We can't pay for this. We need more money. Next slide, please. So the problem here is that there is just no transparency in the nursing home industry. Next slide. This is our related party setup. We've got 2 nursing homes. It's a very small operation. It has a real estate holding company that leases the real estate back to the nursing homes. The management company does business with both of the nursing homes, and then the parent company who owns everything. So we know this exists, but the problem is we don't know how the money moves or how much money is moving in this organization. Next slide. Because CMS requires that each of the nursing homes reports their individual finances through, if you're interested, it's called CMS Form 2540-10. It's also known as the annual cost report. And it is a financial filing that the facility makes that says the facility had these expenses and had this level of revenue, and therefore it had a profit or loss of this amount. So what they do is what I just showed you. They manipulate the income statement, and then they file that document with CMS showing that they lost money. Next slide. And then the second nursing home does the exact same thing. Now the problem, next slide, is that we have no financial filings for the real estate holding company. Next slide. There is no requirement that the management company file anything showing how much money it makes. Next slide. And there is no required filings for the top corporation, except there's a document where they talk about how much of their expenses that they've allocated down to each of the individual nursing homes. But as far as knowing how much revenue the entire chain had, or how profitable it was for the owners of the chain, we have no idea, because the only real financial filings we get are from the nursing homes at the very bottom of this structure, and those are manipulated by the facility. Next slide. So what's our biggest question? Next slide. The question is poor care due to under reimbursement, or is it due to underutilization? So what this question means is, the poor care that we see in the United States right now, is it because we're not paying the nursing homes enough, and therefore they can't put more nurses on the floor? They can't train them better. They can't pay them better. Is it because the government doesn't pay them enough money? Or is it a question of underutilization, meaning these facilities are not using the money judiciously? Instead of staffing appropriately, all the money is going to the owners. And this operation is just a way for them to increase their personal wealth, and they don't really care about individual care. And so that's the question. Is this issue in the United States due to under reimbursement or underutilization? Next slide. And there's a super easy answer for this. Next slide. The answer is we require every chain to file consolidated financial reports that cover the parent all the way to the bottom of the corporate structure, and they disclose all the ownership all the way back to the individual investors. Because what we now have is layers and layers and layers of LLCs and corporations to hide who actually owns these facilities. If you've ever tried to track the ownership of a single facility or figure out which facilities are involved in a chain, it is extremely difficult. And so we believe that there's 2 different pieces of legislation that will fix this. One is transparency of ownership, which again will take it back through all the LLCs, all the way back to the individuals who own those LLCs, or the individuals who are in the private equity pools that are buying nursing homes now. The other piece of legislation is for consolidated financial cost reports. And so what that would be is that would be financial documents that are audited by an outside CPA before they're filed. And it lists all the revenues, expenses, profitability, where the profits are being distributed and to whom. It's got their balance sheets, their cash flows. There are all these accounting documents that will show exactly what's happening with our taxpayer money. And so that is a project that Sam and I have been working on. I've gone to several states and presented to state ombudsman's programs about this, legislative briefings. We are currently talking with several U.S. Congress persons about this to see if we can get federal traction, although I hope we can get federal traction, but we've been focusing mostly on state legislators, because if we can get this passed in a few states, having the large corporations that are operating in multiple states, we will probably be able to get their financial documents in at least one of the states. So that's where we are. And so we've got a situation where CMS is discussing a staffing minimum that would apply nationally. I think it's a good first step. I believe that if the second step is taken, which is this transparency, especially on financial transparency, we will know if they need more reimbursement or if they're just profiteering. And if they're just profiteering, which I believe is what's there, then they're already getting paid enough to increase their staffing. And it's not an unfunded mandate. What it is just lower profits for the owners. And so, but the only way we can answer that question is if we get better financial reporting from the top of the chain down. And then we can have a rational discussion about whether we should increase staffing or increase reimbursement or both. Because right now, we're operating in the dark. We have all of us that are on this side of the aisle who want increased staffing and better care for the residents. And we have the nursing home industry claiming they don't have the money to do that. It's very easy. Just show us your books. If you're really losing money and you're really about to go bankrupt, and the government is saying, show us your books and we'll give you more money, why wouldn't you show us your books? Why instead would you hire lobbyists and pay them millions and millions and millions of dollars so we can't see those books? Well, I think it's very clear. It's because what they're showing us, those books are cooked. And if we get to the real stuff, the party's going to be over for the owners. So that is a very quick rundown of this subject. Next slide, please. This is my contact information. If you want to call or send me an email to discuss this further, like I said, I give presentations all over the country. I talk about this type of stuff constantly. I did not go into the fact that we can show how much profitability is in each facility based on their understaffing. We can actually calculate how much they're understaffed and then how much that's worth. And it's not uncommon for a facility that has, let's say, roughly 100 residents to realize $1 million a year profit based on understaffing. So this is a direct tie between related party usage and understaffing, because related parties suck all the usable money out of the facility And then the facility understaffs because it doesn't have the resources to pay and hire adequate staffing. So it's one hand with the other when it comes to related party transactions and staffing. And we need transparency to figure out exactly what's going on in these chains. And then we can go in after that and take the next step. And hopefully that's additional staffing. Hopefully that's not increased reimbursements unless they actually need it. So anyhow, that's what I came here to talk about. We wanted to leave a little bit of time for questions. So if you've got some questions, there's a Q&A function at the bottom of the screen. Maybe you can put some questions in there, or you could raise your hand and Sam could call on you. Just anyway, that's what I had, Sam. Thank you.
Thank you, Ernie. I can't, we can't thank Ernie enough for the work that he has done. Ernie, I work for a nonprofit. Ernie pays his own bills. He's not a nonprofit, but he dedicates so much time freely to us and to others across the country to really bring attention to this. And just to point out, Ernie and I did a report showing that one very large chain, life care centers, through 3 years, the years 2018 to 2020, ran $1.25 billion through related parties. So don't we have an interest in knowing where that goes? And open up the books. If you need more money, show it. But we're grateful to Ernie, and we're grateful again to Sarah and Donna for sharing their stories. There were some questions about what we can do, and I wanted to point something out. Someone brought up in the chat about a bill in the House, HR 7513. That is a bill that's being moved by Republicans in the House that would prevent CMS from implementing this staffing standard. But not only that, it would prevent CMS from probably implementing a staffing standard ever. So we're still fighting to prevent the derailment of a staffing standard. So what we need to do, and we've been doing this, is tell your members of Congress to not derail the effort. I know it seems trite, but trust me, when you send an email or you call your congressperson, they listen. Letters to the editor saying how important it is for these issues to be addressed, and calls for transparency in nursing home finances. Ernie and Consumer Voice is going to be working in states over the coming years to try to implement this. We need to make sure that money is going to workers like Sarah and to residents like Donna. So with that, we do have some time for questions. Jocelyn is going to try to help us with some questions here. Jocelyn, do we have some?
Yeah, Sarah, I actually have a question for you, if you don't mind popping back on camera. You talked about something that I think we've heard many different workers say, nursing home workers, and also that we've heard many residents talk about, which is that you have a good relationship with the residents in your facility, and they're like family to you. And so can you talk a little bit about what care looks like for the people you work with and for people like Donna when there is better staffing in your facility?
Well, for me personally, I work full time, but there's days where I'm there for 16 hours a day. I spend more time at work than I do my own home. So I work very closely with these people on a daily basis. For me, actually, one of the reasons why I became a med tech, not just to further my education in my new career, but is because as a med tech, I have more time to spend with them. When I go in and pass meds, or if I'm doing treatments, I get to sit down and actually ask them, how's your day going? I get to talk with their family members. I'm close with them as well. I hear a lot from my coworkers who are CNAs, and they stress this to me all the time, that they just wish they had more time like that to spend with them. So with the ratio in staffing, I think it would benefit a lot. And also the longevity of a lifespan of somebody increases as well, because they're not dealing with depression. They're not dealing with isolation. They're not dealing with no contact with, other individuals. I do see a lot of people also, sometimes they don't have family members, so they don't have anybody coming and visiting them. We are all the contact they have. And having that ability to be able to talk with them and listen to them and relate, or whatever it is that they need from us, mentally, is so important as well as physically.
Thank you. I don't even know if you want to ask another question after that answer, because that was that was a really strong and good answer. The only other thing I would say is, Donna, is that something you want to speak to for a minute as well? I know you have lived in facilities with better staffing. What does that better care look like? I know you also spoke to having so much agency staff now, where that they aren't people who know you in the same way Sarah is discussing. So if you just want to take a minute to speak to that.
Okay. Thank you. Yeah, it does make a difference. You really aren't able to kind of develop a relationship over time when people and we have most of our nurses are, and some CNAs are traveling. And my nurse today told me her last assignment was in Hawaii. And so, you don't know when you're going to see someone, even, the next day. So it's hard. The continuity too of care can be difficult. If you've asked a nurse to check on whether a particular medication needs to be reordered, well, they say they're going to do it, and then you may not see them again if that's, the last time they need to see you. And by the next day, there's someone else there, and they have to pretty much start all over again just to kind of find out what has been done, what hasn't been done. So, I might be overcomplicating that particular issue, but it is difficult because it's hard to get to know people when really by the time you do get to know them, they're gone, So yeah, that is a problem.
Thank you. Sam,
Sure.
I'm going to hand it back to you because I think there's only 2 minutes left.
Yeah, I've seen there's been a lively discussion, and I think we were able to address a lot of the questions in the during the presentation. I want to wrap up here. I wanted to also tell folks there the paper we mentioned by that came out, the related party paper from UCLA, which was put in the chat. We're going to be having the authors of that report here for a webinar on April 10th. You can come to our website to theconsumervoice.org to register for that to that webinar. It's going to be a great webinar. They're going to talk about the finances and get really down into the numbers. So we hope you can all join us. And I think, just to wrap it up and put a bow on this, we're grateful to Sarah, we're grateful to Donna for being here. But there's tens of thousands more of folks like them really struggling every day to, one, to provide care, and two, to receive care. And this is our moment. This is our moment here. We're not going to have another moment like this. And we may not like what the proposed standard was, but we can't turn back now. And I hope you all can express to your members of Congress, to your friends, to anyone you know, that this is an important issue. And think of Sarah, think of Donna when we're doing this advocacy. So that's all for today. Could you go to the next slide, Libby? Here's some more information if you want to reach out to us. Again, we're thankful to SEIU for partnering with us on this webinar today, and grateful to all of you for being here, and grateful for your passion. And stay tuned for more. Thank you very much.